Welcome back. For those of you who are back, thank you for coming back. So, as the title says, this is about menstrual cycle, but I don't want you to think of it as menstrual cycle. I want you to think of it that we are looking at the endocrine system. Like I'm saying, as the videos keep coming along, it will become more apparent. So long as you know how one hypothalamic pituitary hormone action works, you will know all of them. It's just a personal favorite that I prefer to know the menstrual cycle because I honestly believe it's the easiest. But you can choose your favorite to say maybe I think that thyroid hormones are easier and you can get to know the thyroid hormone and the rest fall into place. Or you can say human growth hormone is easier and you can choose to know human growth hormone and the rest fall into place. So I do not want you to think of this as I'm learning menstrual cycle. No, you are learning the endocrine system. I just highlighted it as menstrual cycle for study references so that you are kind of aware which video to target for which specific thing you'd like to learn. So, another thing I'd like to get into is this is not necessarily like a so to say educational YouTube video as I think I'd like to call them. I like to call it a study with me video. So we are literally studying together, literally speaking. So what's happening is I read a paragraph or a sentence, I explain it, and once I explain it, hopefully you get the concept. But if it doesn't make sense, always remember at the end of all my PDFs, my phone number is always there. Or you can just ask for my phone number in the comment section. And if you've got questions that I am able to answer, I will answer them. And if I am unable to, I will let you know. But some of the questions were a lot of questions which people would ask me. So I always include them on my notes. So questions are always welcome. So if you haven't watched the previous video, please go back to the previous video. This one will be a little bit confusing. So let's jump into it, yeah? So let's have a quick recap of what we said yesterday. Yesterday we said we talked about menstruation and the menstrual cycle. So menstruation is when a woman removes blood from the vagina as a result of pregnancy not happening. And a menstrual cycle is the sequence of events that prepare a woman's body for pregnancy. So we know that number one, the menstrual cycle starts in the brain. All right. It starts specifically in the hypothalamus. So the hypothalamus always releases a releasing hormone to stimulate either the anterior pituitary or the posterior pituitary. Now, specifically for gonadotropin releasing hormone, it stimulates the anterior pituitary. So the anterior pituitary specifically has got 5 cells. There are 5 particular cells that are in the anterior pituitary that respond to specific hormones. Today, our main focus is gonadotropin releasing hormone. So the cells in the anterior pituitary that respond to gonadotropin releasing hormone are the gonadotrophs. All right. So now, yesterday we also talked about the fact that gonadotropin releasing hormone must be released in a pulsatal fashion. Why? Because if it is not released in a pulsatal fashion, it desensitizes the anterior pituitary. And if it desensitizes the anterior pituitary, there will be less follicle stimulating hormone and luteinizing hormone secretion, meaning that there will be less stimulation of the gonads. Now, we take advantage of this in pharmaceutics because certain drugs we use can either be antagonists or agonists. An antagonist opposes, but an agonist encourages. So there's certain drugs which we can give an individual, like gonadotropin releasing hormone agonists, to desensitize the anterior pituitary to treat certain conditions, which we will have a look at today. So when follicle stimulating hormone and luteinizing hormone reach the ovary, they stimulate the gonads. Remember that the gonads in males is the testes and the gonads in females are the ovaries. The gonads are sex glands. So remember, there's a difference between a sex gland and a sex organ. A sex organ is what you use for sexual intercourse, but a sex gland is, so to say, a secretory gland that assists in anything to do with sexual function, whether it's arousal, whether it's reproduction. A sex gland is the one that carries out that function. So now we can go on to talk about basically the sequence of events after the release of hormones from the hypothalamus. So let's just go over the hypothalamic pituitary ovarian axis. So if you look here, right, the menstrual cycle starts in the brain. All right. Please never make the mistake of thinking it starts in the ovaries. That is not true. Never make the mistake of saying it starts in the uterus. That is not true. Now, if someone is a non-medical personnel and says that, it can be forgiven. But as a medical personnel, menstrual cycle starts in the brain. So the hypothalamus, which has been very nicely enlarged here, yeah, is going to secrete two hormones. All right, which is the anterior pituitary will secrete follicle stimulating hormone and luteinizing hormone. Now, these two guys will stimulate the gonads. So this is B and C, will stimulate the gonads to secrete estrogen and progesterone. Now, we kind of want to figure out what happens after the gonads are stimulated, yeah? Which we will do today. So, um, let's see. Here we go. The first thing is let's talk about two drugs. I actually included these two drugs, which I think are really important. Why must gonadotropin releasing hormone be released in a pulsatal fashion, which I've explained? It desensitizes the anterior pituitary. But let's have a look at how these drugs can be used to treat certain conditions. So drugs that are gonadotropin releasing hormone agonists, for example, buserelin and groserelin, can be used for treatments for endometriosis and other gynecological problems. So groserelin and buserelin, yeah, they mimic gonadotropin releasing hormone. Okay. So when they mimic gonadotropin releasing hormone, they literally look like gonadotropin releasing hormone. I want you to think of it like this. Please, for argument's sake, this is not literal. And I know people take it personally when we talk about Pepsi and Coke, but please don't take this personal. So if we had to take Pepsi and Coke, for me, they taste virtually the same. I'm sorry, they taste the same. If you blindfold me and I drink Coke and I drink Pepsi, I'll think it's the same thing. But then when I remove the blindfolds, then I'll know which one is Pepsi, which one is Coke. I want you to think of it like this. Glycerin and buserelin are Pepsi, and then gonadotropin releasing hormone is Coke. They are virtually similar. They are both carbonated drinks, both have the same flavoring, even if they're both from different companies. So, meaning that gonadotropin releasing hormone agonists spike up how much gonadotropin releasing hormone is in the anterior pituitary stimulation. So, what happens is this: when we administer agonists support, antagonists, so to say, oppose. So when we administer the agonists, they are amplifying what this hormone is already doing. So when we give gonadotropin releasing hormone agonists, this is a, so to say, very nice treatment for diseases because it will desensitize the anterior pituitary. Why? Because we've flooded the anterior pituitary, so we've reduced the number of receptors, which means if we've reduced the number of receptors, we've reduced the response. If the response has been reduced, we have reduced the secretion of luteinizing hormone and the secretion of follicle stimulating hormone. And then, which in turn, because follicle stimulating hormone and luteinizing hormone stimulate the gonads, right? What's going to happen is because they stimulate the gonads, there's less follicle stimulating hormone and less luteinizing hormone, meaning that there's less stimulation of the gonads, meaning that there's less of an effect what occurs in the gonads. I hope that has made sense. So let's give an example of endometriosis. How do these analogs treat gynecological problems? I want you to imagine the scenario. A woman has come to you with very painful menstrual bleeding and very painful defecation. Defecation means very painful passing of stools. After clicking and examination, you discover, okay, this woman has got endometriosis, so you decide to treat this woman. Now, B, do not take this very practical. The treatment of endometriosis depends on what the patient wants. If the patient wants to have children, your treatment is different. If the patient has had children and is done having children, the treatment is different. But just take this in the benefit of hindsight. So you discover she has endometriosis and you decide to administer grosserilin and brocellin. Bearing in mind that, I'll remind you, gonadotropin releasing hormone is a peptide hormone, meaning that it cannot be administered by mouth because if it does, it will not survive the harsh environment of the GI. So if we administer it by a mouth, it will be broken down and it's no longer the hormone we want, so we administer it by injection. So you give this woman gonadotropin releasing hormone agonists. They now is a flood of gonadotropin releasing hormone in the anterior pituitary, and there's desensitization of the anterior pituitary. There's less follicle stimulating hormone and luteinizing hormone secretion. Now, if there's less luteinizing hormone and follicle stimulating hormone secretion, there'll be less stimulation of the gonads. Now, these two hormones, estrogen and progesterone, one of their main functions is that they stimulate, all right, the thickening of the endometrial lining. Now, follicle stimulating hormone stimulates the maturation of the follicles, and we'll get into very big detail about maturation of the follicles. So the follicles are the genetic material in a male and a female. Yes, men have follicles. If you did not know that men have follicles, today you know men also have follicles. Women are not the only ones with follicles. So what happens is if there's less follicle stimulating hormone and less luteinizing hormone, yeah, the follicles will not mature as they should. They don't have enough of the hormone to help them mature, meaning that this woman is not going to experience ovulation. And we'll get into what ovulation is, meaning that the genetic material she's supposed to provide to have a baby will not be mature enough. Meaning, number one, the egg is not going to be mature. Number two, there's no thickening of the endometrial lining. So this woman will experience what we call amenorrhea. Amenorrhea means the absence of monthly periods. And if there's no periods, there's no pain. Endometriosis, in the first place, what is it? Endometriosis is where a woman's body, you've got endometrial tissue outside outside the lining of the uterus, so to say. So this is what happens. Unfortunately for these people, when the cycles of events of menstruation are happening, the thicker, let's assume that this woman has got endometrial tissue inside the vagina. What happens is when the woman's body is preparing for pregnancy, even the endometrial tissue in the vagina is also thickening. And then when menstruation happens, she'll also bleed from the vagina. Now, this is very, very painful because she's bleeding from where she's not supposed to be bleeding. It's kind of like you are not supposed to be bleeding from your mouth. You know that that's a pathology. If a woman is removing blood from her uterus, that's all right. But then if there's an endometrial tissue in the vagina or in the ovaries, it's almost like it's a stabbing pain. It's like you literally take a knife and you are literally stabbing her because she's bleeding where she's not supposed to bleed. So one of the ways you can solve this problem is by inducing amenorrhea, which is the absence of monthly menstrual periods, by giving her gonadotropin releasing hormone agonists. Now, dosage, I will make a separate video on dosage. This is not about pharmacology. I'll make a separate video on dosage. And that's not the only condition we can treat. There are many, many other conditions we can treat. Yeah, so we can have a look at this. This next part where it says, although they mimic gonadotropin releasing hormone when administered continuously, they will downregulate the anterior pituitary and consequently decrease luteinizing hormone and follicle stimulating hormone release. So meaning you have lowered the amount of estrogen, you have lowered the amount of luteinizing hormone, you have lowered the amount of follicle stimulating hormone. So all the ingredients necessary for a normal menstrual cycle to occur are not there. So meaning this woman will not menstruate. On top of that, these analogs prevent pregnancy. Now, I will talk about my preferences of birth control. I would actually prefer to administer gonadotropin releasing hormone agonists to a patient as opposed to giving progesterone only contraception or combined oral contraception. That's just me. Different doctors have got different preferences, but I will explain my reasoning. Other doctors prefer progesterone. But I'll get into why I would not prefer that. I'll get into it. So we can continue to read. This has effects on ovarian function such that estrogen and progesterone levels also fall, and most women using these analogs become amenorrheic. These preparations are used for treatments for endometriosis and to shrink fibroids prior to surgery. Fibroids feed off estrogen the same way you eat shima. Then shima is estrogen. If estrogen levels fall, fibroids starve and begin to shrink. The same way, if we withhold food from you for 1 month, you will also shrink. Number four, what is amenorrhea? Amenorrhea is the absence of monthly menstrual periods. So now let's look at how we can treat this condition that we call fibroids. So fibroids are just like non-cancerous growths in the uterus. As my consultant once said, an idle uterus is a fibroids workshop. So what this means is this. So if you've never had children or you've never been pregnant, you might be peacefully growing fibroids as you are watching this video. Mwah. Welcome to the fibroid club. So the thing is, estrogen feeds certain tumors. All right, it can feed breast cancer cells. It can also feed fibrous tissue, fibroids as well. So now fibroids. Oh my, I didn't put a picture of fibroids. Okay, I will do that. So fibroids are basically, I want you to imagine that this is a picture of endometriosis, but there are growths in the uterus. They are very big, big growths, yeah? So what happens is estrogen and progesterone kind of like feed these growths. So long as you've never had a baby and there's no inhibition of estrogen, these growths keep going bigger and bigger. Estrogen is their go-to, it is their power food. So what happens is this. If a woman is presented with fibroids and they're very, very huge, um, healing time would be a lot on your patient. So what you want to do is you give gonadotropin releasing hormone agonists. So let's look at the sequence. You give gonadotropin releasing hormone agonists. The agonists desensitize the anterior pituitary. Desensitization of the anterior pituitary leads to less secretion of follicle stimulating hormone and luteinizing hormone. Less secretion of follicle stimulating hormone and luteinizing hormone leads to less stimulation of the gonads. Less stimulation of the gonads is going to now lead to less production of estrogen and progesterone. Estrogen is the one that feeds fibrous tissue. So meaning that if the estrogen is not there, the fibroids will starve and begin to shrink. Now, for some women, they're completely responsive to these analogs and you don't have to do surgical intervention. But for some women, the fibroids are very big, and after they've shrunk to a certain degree, then you're like, okay, now I can take them out. I'd like you to think of it like this. In medicine, we always want to give the patient the best treatment possible. If you can avoid surgical intervention with minimal risks, do that. If you take a woman up and open her up and the fibroid is this big, the healing time is very, very long. So a lot of gynecologists, and I've actually seen it, would prefer to shrink them first. The only time they don't shrink it is if the level of uncomfortability in a patient is a bit too much, then they don't have a choice but to just do a surgical intervention, because fibroids can press on the bladder. The woman is always feeling like she has to urinate. They cause a lot of uncomfortability and discomfort, but we'll look at those in a separate video. So that is one of your treatment plans of a woman with fibroids. That's another treatment plan for a woman with endometriosis. We have other conditions like adenomyosis, but we'll look at that in a separate video. All right. You can also use these analogs to treat adenomyosis. So now, here is the question of what is endometriosis, which I already explained, but like I said, this is a reading session. I am literally studying with you. So, this is a condition resulting from the appearance of endometrial tissue outside the uterus and causing pelvic pain, especially associated with menstruation. This causes painful menstruation because the tissue that is not supposed to be shed is being shed off. Now, this actually causes conditions like infertility, but we'll look at that in detail another time. So this endometrial tissue here, whenever the woman is menstruating, right, it is going to be shed. And when it's shed, the body picks this up as scar tissue. Now, the thing is, what happens is whenever you cut yourself with a knife, it to heal where scar tissue forms. There will be a lot of bandwidth of scar tissue that can actually form in this woman's fallopian tube. Meaning that if an egg is released from here and tries to pass through the fallopian tube, it will be blocked by this bandwidth of scar tissue. Meaning that even if a sperm is traveling up the uterus, when it reaches here, there's this band of scar tissue preventing it, and this woman is going to experience infertility. So it's a very, very common thing, but there are ways you can treat it. Like I said, we'll get into it. Your treatment of endometriosis depends on what your patient wants. And one of your telltale signs is menstruation is not supposed to be painful to the point where someone is scared shitless, yeah? If a girl is scared shitless, so beyond all reasonable doubt, endometriosis might be one of your differentials. The differential means a possible diagnosis, so to say, apart from the diagnosis you have come up with. So, assuming you've done your physical examination and you've clicked a patient, then you say, oh, this patient has got adenomyosis. Endometriosis is a differential because even adenomyosis causes very painful menstruation. Adenomyosis is different from fibroids, but they may look similar in brackets. So adenomyosis is where there is endometrial tissue in the myometrium, this myometrial segment here. So what happens is when the woman is about to menstruate, the uterus becomes extremely huge, enlarged actually, because what is happening is whenever menstruation is about to occur, that even the endometrial tissue in the myometrium is also thickening. So meaning that the uterus is also becoming thick. So now when she bleeds, it's like you are literally stabbing her uterus with a knife. Adenomyosis is equally very, very painful. It is a very good differential if you come across it. Another one it can treat is okay, no, painful menstruation that is not associated to adenomyosis or endometriosis or ovarian torsion. Ovarian torsion is also a very nice differential. You can give what we call mefenamic acid. Mefenamic acid is a prostaglandin inhibitor, and I'll teach prostaglandins in a separate video. It reduces the pain. Sometimes menstruation is just painful, or other times, like I like to say, sometimes girls are just pussies. You should tough it out. We move forward. And this video shows how you confirm a woman has got endometriosis. They open a woman up, they do a little bit of staining. Now, I'm not really sure how the staining is done, but I know if it turns purple, then you confirm your diagnosis that you found endometrial tissue outside the uterus. So it confirms your diagnosis of endometriosis. So, pituitary gland. Gonadotropin releasing hormone stimulation of the basophil cells in the anterior pituitary gland causes synthesis and release of gonadotropic hormones, follicle stimulating hormone, and luteinizing hormone. This process is modulated by the ovarian sex steroid hormones estrogen and progesterone. So always know the difference between a steroid and a peptide. Steroids, we can give them by mouth, but peptides, we give them via injection. Reason being is that steroids, when you administer them by mouth, they can cross the phospholipid bilayer, rather diffuse through, and survive the harsh environment of the GI. And I'll make a separate video on cell membrane physiology so that you really get an idea of mechanism of action of certain drugs. If a drug is not administered by mouth, we want it to survive the GI, or we want it to have a faster action, which we'll get into. So what are gonads? Gonads are glands that produce hormones that are involved in reproduction and other functions of the body. These hormones include estrogen, progesterone, and testosterone. The female gonads are the ovaries and the male gonads are the testes. So number 7 reads, what is gonadotropic releasing hormone? These are hormones that stimulate the activity of the gonads, glands involved in reproduction. Low levels of estrogen have an inhibitory effect on luteinizing hormone production, which is negative feedback, whereas high levels of estrogen will have an increase in luteinizing hormone production, which is positive feedback. So now this is where we'll end here for the day. And I will see you guys next time. And I hope you've enjoyed it. Please leave a comment and I will really appreciate you. And if it makes sense or something isn't clear, always let me know. Yeah. Bye.